Good evening, everyone. Welcome to the Bay Area Long COVID Town Hall. First, I'd like to start off with some housekeeping. If you are interested in getting Spanish interpretation, see the globe at the bottom of your screen and select Spanish or English. Also, if you're interested in having any questions, if you have any questions, please put your questions in the Q&A icon that is also at the bottom of your screen. This town hall will be recorded and will be available at a later date with a link. Again, good evening. My name is Lisa Teeler, pronoun she, her, and I'm the Executive Director of the Bay Area Community Health Advisory Council, also known as BACHAC. We are a grassroots community health organization based in San Mateo County, focused on eliminating health disparities through connection to services and resources, health education and advocacy in diverse communities across generations. In addition, I am honored to serve as the co-lead for Umoja Health San Mateo County with Dr. Kala Mehta and Shaquille Ali. Umoja Health's mission is to build coalitions that increase community capacity to achieve health equity. I'd also like to take this opportunity to acknowledge our partners and sponsors that helped to put this town hall together. Peninsula Healthcare District, Umoja Health Bay Area, Rafiki Coalition, and UCSF. Before we begin, I'd like to do a land acknowledgement that we stand on the lands of the Ohlone Nation and that we lift up and honor our Native and Indigenous brothers and sisters. And for more information, see the link at the bottom of the screen where you can learn more about Native brothers and sisters, not only in the Bay Area, but across the world. I'd also like to take this opportunity to acknowledge the loss that many of our communities have suffered, losing loved ones, friends, neighbors, coworkers, their loss of job or their home, and to all those who continue to suffer, particularly those who are suffering or may not know they're suffering from long COVID. I'd like to also just let you know that who are those folks that are working on this long COVID study? This is a team of UCSF doctors with different types of training that are working together to really understand the long-term effects of COVID on people and communities in the Bay Area. They are trying to answer some of these questions. This is a unique two-phase partnership to understand long COVID, where researchers, the local health departments, in this case, San Francisco and San Mateo County, and the community are trying to work together to really address the issues that are facing our folks who are suffering from long COVID. This is the way for us to tell their story and to learn what is actually happening in our community. I'd like to take this opportunity to introduce two of those incredible individuals that are working on this study together. Our first speaker will be Dr. Kim Rhoads. She is an associate professor of epidemiology and biostatistics at UCSF. Her formal training is as a general and colorectal surgeon. She has additional training in basic science, healthcare disparities, and health policy research. She also trained as a community advisor at the Center for the Third World Organizing during medical school. In her current role, she serves as the Associate Director for Community Engagement at the UCSF Cancer Center, and as the director, but really the founder of Umoja Health, a community-run COVID testing and vaccination initiative where all the services are provided by community partners. Dr. Rhoads earned her medical degree at UCSF, a Master's of Health Science at UC Berkeley, and a Master's of Public Health at Harvard. Our second distinguished guest speaker is Dr. Stephen Deeks. He's a professor of medicine in residence at UCSF. He is recognized as an expert on the impact of viral infections on inflammation, immune function, and health. Dr. Deeks has published over 600 peer-reviewed articles, editorials, and has been invited to review on these and a variety of other topics. He is also one of UCSF's principal investigators for the recovery study, an NIH-funded program that you'll hear more about. Dr. Deeks has contributed to several national and international meetings on the topic and provided expert testimony on long COVID to the US House of Representatives Subcommittee on Health. He was elected to the American Society for Clinical Research and the Association of American Physicians. He also serves on the Scientific Advisory Board for Science Translational Medicine. So without further ado, I turn the virtual mic over to Dr. Kim Rhoads.
Thank you, Lisa, for that introduction. And also, I want to thank you for spearheading this effort to bring this information to the community and to do it in partnership with representatives from other Umoja jurisdictions in San Francisco. So thank you all for pulling together and for caring about the community and wanting to make sure that we get the information that we need in order to stay as safe as we can in this historic pandemic. Okay, so what I really want to do today is kind of set the stage for what you're going to hear from Dr. Deeks. I want to help people try to understand what really is happening in our bodies with COVID, because I think a lot of what has gotten in front of us is the idea that it's just like the flu, and so it's not a big deal if you get infected. And I think when you ask the question, why does it matter if I get infected? I think the answer is long COVID. And I think with the volume of people that are going to be impacted by long COVID, I think we really need to take this seriously. The second thing I want to just say is that it seems like there's a lot of shame around getting infected. And so what that means is if people develop symptoms of long COVID, they may be less willing to disclose or share those stories. And we really need those now because there's so much we don't know about this virus. And so I want to open the space for it to be okay for people to have had COVID, but also to be able to say that some of the symptoms that they may be feeling afterwards really are related to long COVID. So just briefly, the point of long COVID, and just to kind of set a little bit of a definition, is that like the reality is the majority of people do fully recover from long COVID. And that's this little guy here. So there's an infection and then there's an illness, and over time, then that comes down and goes back to normal, so to speak, or at least post-acute infection. But some people don't actually fully resolve, and they become what we have come to call long haulers, or they have issues with long COVID. And what those issues relate to is physical and mental health symptoms, that don't go away after having been acutely infected. And it can happen to anyone, and we really don't have a lot of information about who will be the most impacted. There's some other names for long COVID. You'll hear a little bit about more about that from Dr. Deeks. So in order to understand long COVID, I think we really need to understand how COVID works and who is at risk. Not so much who is at risk, but like what is COVID doing in our bodies, and then how does that put us at risk? Like what parts of our bodies are affected? So what I'm going to talk about is how does COVID infect the cells in your body, which cells can be infected by COVID, and then what are the consequences of infection in those various cells. I'm just briefly going to touch on how common it is, because I think that's a big question that everybody's got, and then give a little bit of a call to action on what you can do. So how does SARS-CoV-2, which is also known as coronavirus or Rona, or whatever you like to call it, cause COVID-19, which is actually the disease associated with coronavirus? And I do see there's a question already in the Q&A, and that's great. So please go ahead and put questions in the Q&A. We will have a long opportunity for discussion after the talks. So the way it works is kind of like a key and a lock kind of scenario. And the spike protein on the coronavirus, which is why it's called coronavirus, is the spikes of the crown, acts as a key. And the lock that it's looking for is called the ACE2 receptor. And that ACE2 receptor lives on a lot of different cells in your body, and I'll talk about where that is coming up a little bit later. But the spike protein effectively unlocks the door to the cell and basically takes over your cell's own machinery and forces your cell to start making more coronaviruses. So I want to get you oriented to this image right here, because I'm going to show you a little video. And it's going to start with this and it's going to end with this. And so I just wanted to get you oriented to the virus, which is going to be represented as this pink circle here. The spike protein, which is dangling off of the virus. And this is kind of, electron microscopy, or this is kind of the visual image that you would see if you could really, really magnify down and get a good glimpse of the spike protein. And once it's done helping the virus actually invade the cell, it ends up in this configuration here. So I just wanted you to kind of have the visual for the next video that I'm about to show you. And this is really, I think, a remarkable depiction of how a coronavirus actually contacts your cells, uses the spike protein as a key to open a lock, the lock on your cell, and then effectively fuses itself with your cells. Okay, there's no sound here, so don't anticipate any sound, and I will play it twice. So there you see the spike protein. That's what all of our vaccines are trying to help us make antibodies to block that thing because it's evil. And here it is contacting its lock, which is the ACE2 receptor, that little blue thing. That changes its configuration and allows it to actually start to bind itself to your cells. And this is happening with multiple spikes and multiple ACE2 receptors that allow the virus to be pulled right down against your cell and to fuse with your cell. Okay, I'm gonna just run that one more time. Because I remember when I first saw this, it's like really looking at a monster invading your cells, and how clever the spike protein configuration is. So the configuration is going to change once there's contact made between the spike protein and the ACE2 receptor. Configuration changes, drops down its little anchor, anchors to your cell, and then pulls the virus right down next to your cell and fuses that membrane, which allows the material from the virus to enter your cell. So what happens once the virus makes contact and enters the cell? The genetic material from the virus is then injected into the inside of your cell. Your cellular machinery is commandeered to make more viral genetic material and more proteins to wrap the virus in. More virus is packaged, and then it's expelled out the sidewall of your cell to go on to infect other cells in your body. I just want to do a sidebar here to help people get a visual of why antibodies help, and therefore why vaccines help. Now, I don't recommend that you go out and get infected so that you can get antibodies, but what this is trying to show you is a visual image of how the green antibodies here bind to the spike protein that does not allow the spike protein to dock appropriately in the ACE2 keyhole, if you will. So if you can imagine, you're trying to come home from work and you pull your key out of your pocket, but oh, it's got that piece of gum that you left in your pocket is wrapped around the key. So the key no longer fits in the lock. That's kind of how antibodies are working. They're gumming up the ability of the spike protein to bind the ACE2 receptor. So that's just a little sidebar to remind you that vaccination is a good thing and we need to keep at it. So what happens after the virus invades? I'm going to just use the example of the lungs because that's what we're most familiar with in terms of developing a pneumonia. So the virus invades through the pink cells in the back of your throat and your nose called the mucosa, makes its way down the windpipe into the small branches of the windpipe and the air sacs where you're breathing in oxygen, that oxygen is going to your blood. That's the way things should normally work. Those small sacs are very thin walled, and the blood vessels that are going to pick up the blood run right along them. And because the wall is so thin, the oxygen can pass into the blood and turn cells which have no oxygen into red cells that now have oxygen. So as these cells are passing by, they're picking up oxygen. This is the inside of the lining of those air sacs. You're taking a big deep breath in, pulling in oxygen. That oxygen is oxygenating your blood. You see how thin this layer is here? It's really important that it is thin because the oxygen needs to just diffuse across. But what happens when there's infection is you get a lot of inflammation. And so you get this thickening of that lining, making it more difficult for oxygen to pass across this lining. It's got to pass through all kinds of fibrin and fluid and kind of yucky stuff. And so the oxygen doesn't get to the blood. People then can feel short of breath and also just have general dysfunction because the blood has a lower oxygen level. That's what's being checked when they put that little thing on your finger, the pulse ox, looking for how much oxygen is in the blood. So you can see how inflammation can really get in the way of normal functioning of the lung tissue. And similarly, inflammation can have a negative impact on other organs as well. So where might you have dysfunction because of inflammation or because of infection with virus? Anywhere where that ACE2 receptor is residing. And so I think we're all familiar that it's in the nose because that's the way we take in COVID. That's the most common route. But it's also in the lungs, and that's why we were seeing pneumonia. It's also in the small intestine. And you may know people who had COVID who had symptoms that were related to GI distress. They had terrible diarrhea, or they had vomiting, or they got dehydrated on the basis of that. It's because there's inflammation also in the GI tract that can occur because the cells in the GI tract also have this ACE2 receptor. The heart's got ACE2 receptors. The pancreas has ACE2 receptors. And I know we've been hearing a lot about diabetes post-COVID. So you have to wonder if it's related to this, to damage and dysfunction of the pancreas. And then, of course, these receptors are also in the brain and in the central nervous system. So you can also have impacts of inflammation and how that affects your ability to function, i.e. to think. But the topper for me, and the thing that I think we have not paid enough attention to, is the fact that all the blood vessels in your body have these ACE2 receptors. And basically what this, big technical title is telling you is that when the virus contacts the ACE2 receptor and gets into the cells that make up your blood vessels, it leads to blood clots, okay? So this is important because blood vessels don't heal well. They're not, endothelial cells don't heal well. They're not very friendly. When you injure them and they get inflamed, they scarring, and that scarring in a blood vessel can represent a clot. So you can see what can happen over time. And this is really giving this is more of a depiction of endothelial cell injury. So blood vessel cell injury and response to inflammation and deposition of fatty materials, of lipids. And that's what can cause a heart attack when this gets blocked up. But the point I'm making is this pathway and this inflammation is the same pathway that gets you to the creation of dead cells and blood clots. So that will block the blood flow through these blood vessels. So any organ can actually be impacted by the effects of COVID without being directly infected with COVID, because your blood vessels go everywhere. You need your blood vessels for everything. So important to be aware that COVID is a vascular inflammatory disorder. And I don't know if you all remember COVID toes, but that was some inflammation in the blood vessels in the skin of the toes. So again, it's a vascular inflammatory disorder. It's not just pneumonia. So it's not just the flu, because the flu doesn't do all of this. So just to try to get a sense of how common long COVID is, it's been really difficult. And in 2021, there was what was thought at that time to be the best population-based study. And why, when we say population-based, what do we mean? We mean that it was a random sample of 791 people who were 366 of whom were willing to complete the interview based on a phone call asking about symptoms. And what they found there was that 31%, so about 1 out of 3 people, had symptoms 4 months after infection. Commonly, they found fatigue, shortness of breath, issues with loss of taste and smell. And the point that it's population-based because it's actually hard to do this kind of sample. I'm sure people on this call know a lot of folks who have had COVID. If you go and ask all of them, do you have long COVID? That's not really a population-based sample, right? Because it's limited to the people that you know. It's not a random selection of all the people represented in the area where you live, for example. But this was one group only, so that's a limitation. It's a population base of Long Beach Health Department, so that's Southern California. We are Northern California. The COVID rates have been different between the two places, so you might expect that the long COVID rates would be different between the two places. And also this was done very early, so we don't have any information, for example, about what is the prevalence of long COVID in after the Omicron wave or after BA.5, the last one that we just went through. So there's got to be effectively better ways to collect this data. And again, this is just a slide that I borrowed from Dr. Peluso, who's also on the team, just kind of re-emphasizing that when you're looking for a population-based sample, you really want a smattering of everybody. For example, you don't want just white people, which often happens in a lot of studies that we do. We don't want people who were just hospitalized because their disease may be more severe and that may predict more long COVID, we don't know. You want a mix of people who are managed at home who had sort of mild disease, and you want a mix of people in terms of race, ethnicity, as well as like if you can get that mixture of like lifestyle as well, there's just a lot more information that we can understand and extrapolate to all populations, not just to the specific population that was studied. So the more recent household survey, so this is not hospital-based, these are people who were able to manage at home, conducted through the CDC with the National Center for Health Statistics, found that that about 7.5% of people that they called, because this was the household pulse survey, so they actually call people, 7.5% of people still had symptoms up to 90 days after having had COVID. You can see that women were more likely than men to have long COVID. And you can see here in this bullet point that there were some differences by race ethnicity. So 9% of Hispanic adults compared to 7.5% of white adults, 6.8% of Black or African American adults, and then non-Hispanic Asian adults was around 4%. So you can see that there are some differences. And then I want to point out these geographic differences. I'm not meaning deliberately to or intentionally to skip over differences by sexual orientation. You can see those here. But I want to point out the geographic differences because I think that's part of what's important about the long COVID study that NIH is funding now, because it's 15 sites around the country. We really need to know what's happening in these different pockets where some communities have been hit really hard, particularly the South. And that's, of course, of interest to me, in part because of the density of African-American people who are there. But what you can see is that the rates in Kentucky, Alabama, Tennessee, much higher than some other states, Maryland, Virginia, and Hawaii, for example. So finally, I just want to give you some sense of like, what can you do at this point? First of all, I think we need to validate for people who are experiencing symptoms, people who had asthma before they got COVID and now their asthma is worse, people who had high blood pressure before COVID and now their high blood pressure is worse, right? We want to help them not, downplay the potential impact of COVID. There are a lot of anecdotal stories going around of people being told, well, yeah, you had COVID, but you really should be able to get up and, get back to what you were doing and get back to normal, and not suffer from that fatigue and that brain fog and the sort of like trying to I like to say, moving like a snail in molasses, like just feeling stuck. Because it is real. And I think we need to support each other to understand that it is real so that folks can try to take action to address as soon as we know what we need to address, the ways to get better control over your blood pressure, because whether or not your worsening high blood pressure is due to long COVID, it could still cause a stroke. So we really just need to pay attention and try to help people pull back from the shame of having had COVID, or the shame of not feeling that they have as much energy as they used to, and that they can't do some of the things that they used to be able to do. So stay informed. Feel free to join us at an Umoja meeting in your jurisdiction. We meet and cover what's happening with COVID in San Francisco, San Mateo, and Alameda County. I'm going to show you who the organizations are on the long COVID cab that are related to this study that you're going to hear about, and the research team that you saw. Keep up with them, because your suggestions to them can be brought into that long COVID cab to figure out, do we need to have more seminars and forums like this, and how can people plug in and connect with what's available to address their symptoms and complaints. And then finally, take action. Try to avoid getting COVID-19. Get vaccinated and please get boosted, and please wear a high quality mask. And I think those things also apply for people who have already had COVID. So it's not like all is lost. You've already had COVID. No, we're still rooting for you. We still want you to be well. And what we don't know is, does the number of times that you've had COVID make you more susceptible to having long COVID, or to having complications of COVID, like the clotting kinds of things that can happen. And just to really bring it home, the clotting things that happen in the heart cause a heart attack. The clotting things that happen in the blood vessels to the brain cause a stroke. So this is really serious, and is also happening in younger populations. It's not just the elders who are suffering from these effects. And in fact, in the CDC study, the age difference was favoring elders. Elders were found to have less symptoms of long COVID than young people. So this is really important. And then finally, consider joining the Recover study. Here's our email, figuringoutLongCovid@ucsf.edu, or you can call 415-353-9306. These slides and this video will be available to everyone, so you can get those numbers off of there. I want to thank our long COVID community advisory board. So these are the organizations. Please identify the ones that are in your area to reach to get more information, to make requests about information that you think we should be bringing out into the community. And we have representation from San Mateo and San Francisco, as well as Alameda County. And I think Santa Clara is also in there. So thanks, that's all I have to say. And now Dr. Deeks is going to talk about long COVID itself and the clinical manifestations, and hopefully you have a foundation for understanding why these things can happen and are happening to people after having acute COVID. Thank you.
Thank you, Dr. Rhoads. So that was a perfect introduction. Hello, everybody. I'm gonna just kind of tell the story about how everybody sort of found out about long COVID in 2020. And then walk through how people present and touch a little bit on some of the epidemiology, just comment on some of the stuff that Dr. Rhoads had mentioned. And then sort of outline why this is happening and what we're gonna do about it. And hopefully there will definitely be a lot of time for questions and answers. We have a discussion, all this stuff. It's all very controversial. This is a very rapidly moving area of medicine right now. Okay, so I find the story fascinating. 2020, of course, was a dramatic year on many levels. We were actually in February, March of 2020. We had a very big program in San Francisco, trying to figure out how HIV makes people sick, even in people who are on antiretroviral drugs, people who are treated. And we were finding out that HIV was causing chronic inflammation and so forth. So on March 19th, 2020, we shut down, the city shut down, the cohort shut down, everybody went home. But we had this sort of new virus infection that everybody was talking about. So we basically, literally within a few days, shifted all of our work on HIV to COVID. And this was March, April, May 2020, when we really had no idea what was going on. As you can remember, everyone was really focused on the hospitalized patients and people were dying. But we we were well aware then that there were people who were not that sick, but we were quite concerned that there were going to be some long-term effects. So we started a cohort, it's called Link. It's now part of Recover, and I'll talk a little bit about that at the end. But in society, what was happening around this time, April, May, is the social media just exploded with stories of people not getting better. And very quickly, there were hundreds of advocacy groups that developed around the globe talking about long COVID. And these were community-based groups, largely communicating with each other through social media, and then through the New York Times and sort of the mass media. And then Congress got involved. And by the end of the year had actually, mainly because of the effect of the community advocates, had nothing to do with the scientists, came up with over $1 billion to go to Recover. During that time, we were sort of beginning to sort of try to figure out what's going on. But I will tell you that I think the medical system failed, because initially in the summer of 2020, when people started talking about this, 90% of my colleagues said, well, this is just people who are crazy, or people are depressed, or people who don't want to work, who are coming up with the new ways to get around the system. And it took several months for, actually, even up to today, there's still a fair amount of skepticism in the medical community, which I think is very unfortunate. But we are slowly overcoming that, because everybody now knows someone who's got long COVID. And so I think people are beginning to accept that it's real. There is a lot of jargon, a lot of names, PASC and PACs and PICs and long haulers and long COVID and so forth. Essentially what happens is that you get the virus, and then you recover, hopefully. And then I would say the majority of people are fine. But there are all these different sort of things that can happen. People can get diabetes, people can get strokes, people can get heart disease, as a consequence of COVID. And then people can also get long COVID or long haul. And so these are quite different things, right? So there's this umbrella term called PASC. That's what NIH uses, post-acute sequelae. It's everything, including all these things, every disease, and almost all the things that we think about, all the things that people make sick, seem to be more common after COVID. But what we're talking about today, what most people are talking about, is not that. They're not talking about PASC, right? We're really talking about long COVID, which is part of PASC. And this may be boring, but essentially we have to get through the semantics here. And long COVID or long haul is a term that the community came up with. And now I think the biomedical establishment is basically accepted. And essentially it's this whole laundry list of difficult to explain symptoms that people can get. Now, what are they? Essentially, it's everything. To a certain extent, almost all parts of the body can be affected. People can have anxiety, mental health issues directly related to the infection. Obviously, loss of smell, loss of taste is quite common. Respiratory issues that are difficult to explain can persist. Fatigue is a major issue. Post-exertional malaise is quite classic. This is actually people who are doing okay, but they exert themselves at either exercise or concentration, and the next 2 or 3 days, they're completely wiped out. That's a big issue. Palpitations and having low blood pressure when you stand up, feeling dizzy, very common, can be also quite disabling. Gastrointestinal stuff, so forth, pain. So these are all different symptoms that can accumulate, and everybody experiences their long COVID somewhat differently. And I'll go a little bit into that shortly. But that's kind of what long COVID is. So you have diabetes and heart disease, that's part of PASC, but really most of us are thinking about this stuff in terms of what is long COVID. How is it defined? Basically, everyone says, if you get COVID, if you get the infection, a lot of people are sick for 4 to 6 weeks. Actually, it seems like it's quite common these days with Omicron, but after 12 to 16 weeks, they're fine. So we generally think of long COVID as something that starts after about 4 months. If you're still got something going on about 4 months, that's long COVID. How common is it? Who's at risk? There have been, and Dr. Rhoads mentioned a few of these, there have been hundreds of reasonably high quality studies now that come out, and the numbers are all over the place. Anywhere from 5% to 50% of people who have the infection 4 months later have something going on. Now, part of that's how it's defined, right? I mean, in many studies include hair loss as something that's long COVID. And trust me, if I had gotten COVID in my late 20s, I would have blamed it on my current hair condition on the infection, when in fact it was going to happen anyway. So there's a lot of noise in some of these studies. Personally, I think that the long COVID that we think about, the one that is disabling, is not as common. It's not 40%, probably not 20%, maybe it's 5 to 10%. And that's kind of what is sort of popping up in some of the more higher quality studies. So 1 in 10 people get this, 1 in 20, hopefully a little bit lower going forward, but that's a lot of people because a lot of people have gotten infected. And so this study right here that came out of Scotland is actually one of the better ones. It was in the news last week, so I figured I'd show it. Thousands of people who had COVID were asked how they were feeling. People who didn't have COVID were asked how they're feeling. And they came up with the similar numbers. But what was really interesting here and what pops up all the time are the risk factors. Women is a major risk factor. We don't know why. How sick you are. If you were hospitalized versus not, that's a big factor. Age tends to be, certain types of long COVID are more common in younger, but in general, it's related to age. Pre-existing conditions, socioeconomic status. In the studies that measure this, mainly the non-American studies, it keeps coming up that people see more long COVID in communities that are basically a little bit more disenfranchised, poorer, and so forth. That's typically how this is measured in the British and Scottish studies, and I'll come back to that at the end. Obesity, blood pressure, these things are all consistent predictors. Now, I do want to touch on this issue because it's in terms of what impact these determinants, these social economic determinants of health have on one's risk of getting long COVID. In the United Kingdom, where they've studied this the best, these factors, mainly poverty, but to a certain extent also race and ethnicity, have been associated with increased risks of getting long COVID, mechanism unknown. In the United States, we really have no data on this because everything that's been done in the United States have largely been these electronic medical records, right? There's been no really, except perhaps the study in Long Beach that Dr. Rhoads mentioned. It's mainly things like Kaiser, which you have to be, not everyone can afford Kaiser. The major player in the United States has been the Veterans Administration System, which is 90% men, mainly older, mainly white. So we don't really have any good idea of what's happening in the United States across all the communities, rural and urban and so forth in the United States, because it hasn't been measured. And that's what we're trying to do in this recovery thing. And there are a lot of reasons why we believe when we do measure this, that certain communities are going to be much more affected by long COVID. The things, access to vaccines, if you don't have good access to vaccines, your risk of long COVID is much higher. Therapy, if you don't have access to therapy, if you don't have insurance, you don't have access to the wherewithal to get on various acute therapies, for whatever reason, your risk of probably developing long COVID is going to be higher. The worst long COVID that we see came from 2020. A lot of people who were actually unable to socially isolate. You know, I basically have been working in my media room where I am right now since 2020, but restaurant workers couldn't do that, food handlers. They were out there and they were being exposed and getting high levels of exposure. And I actually think ultimately this is a big issue because most of the worst long COVID we see comes from 2020, when people who were not able to protect themselves for whatever reason we're getting high exposure to lots of virus, and that actually has turned out to be a major factor in terms of long COVID. A lot of comorbidities that are quite common in various different communities are associated with long COVID. So we really need to, and genetic factors is also likely an issue. Long COVID in many ways is quite similar to some of the rheumatologic diseases like lupus, which is much more common in women than men and much more common in African Americans than others. And we don't know why, but a lot of the science that's coming out are suggesting that there's some common pathways here. So we really need to pay attention to this issue. All right. Are there different types? Yes, there is the cardiovascular stuff, the palpitations. There's the pulmonary stuff, trouble breathing. There's the brain fog stuff. These are different. And then there are actually things that are very, very similar to chronic fatigue syndrome that sort of goes across these things. And then there's something called POTS, this orthostatic tachycardia syndrome. So there are different phenotypes or different subsets, and everyone experiences quite differently. And this is proven to be a problem because this disease is so complex. It's so hard to measure. And everyone experiences it differently. And there are no specific tests. There's no diagnostic test that says people have long COVID. And it goes up and down, so it waxes and wanes. I mean, so this lack of clarity as to how to measure it is the problem number one, because if you can't really measure it easier, drug companies can't develop drugs to make money. And if they can't make money because they don't know how to study this stuff, because they can't measure it and they can't get the FDA to prove it, they don't invest. And if they don't invest, we don't get therapy. So this is a big problem right now in terms of why we don't have a lot of treatment. It's just so hard to measure. And again, there are no tests. Can it be prevented by vaccines? Certainly. The vast majorities of studies have shown that if you're vaccinated, up to date in your vaccines, your risk of long COVID doesn't go away. It's there, but it goes much lower. Is it less common with Omicron than with Delta and before? Seems like it. Studies are now coming out that it is less common, although we never know if it's because everyone's been vaccinated. Everyone's already had COVID before and they're protected. We don't quite. It's all kind of a mess. But the current data to me suggests that, fortunately, vaccines prevent it and reduce the risk. And at least with Omicron, the risk is a lot lower than what we saw before. Do people get better over time? Yes, for sure. Again, if you wait 4 months and then you start the clock, then I don't know, half of people over the next year or two will continue to get better, and the other half not so much. Why are there no clinics? I'll come to that. Does this occur after other infections? This is one of the most interesting things. You probably have heard about post-Lyme disease, chronic Lyme. It turns out we're now realizing that after multiple different kinds of infections, Ebola, Zika, possibly not necessarily not flu, but a bunch of infections like dengue related to Zika, certain types of dysentery, as I said, Lyme. There's a whole long list of infections that actually, West Nile infection and so forth. When people go back, they're now realizing that 10% of people who got these things had all this vague stuff going on that was ignored. And people said, oh, you're getting old, you're depressed, or this or that. Turns out that this is actually, this long COVID thing can happen with a lot of different infections. And it's remarkably similar in terms of how it presents. So we've ignored that. And the whole chronic fatigue syndrome thing, I'm beginning to think is related to certain infections people didn't know that they had. Even the SARS infection from or SARS-1, same exact type of outcome that we're seeing now with SARS-CoV-2. So So all these things quite related. A lot of them end up with post-exertional malaise and pain at the same rates as what we're seeing with COVID. All right, what is the cause of marginal therapies? So what is the cause? We don't know, but we're making progress. There's a lot of money being spent on this now, and there are 5 major pathways, right? So Dr. Rhoads talked about, you met that video. The virus gets into cells expressed in ACE2 and kills that cell and causes tissue damage. As Dr. Rhoads said, these cells expressed in the ACE2 are all over the body. So in the acute infection, you can get tissue damage and you can get nerve damage and so forth. And it takes a long time for that stuff to recover. So that's the acute thing. And so you just don't want to get infected. But then there's the persistence. And this is probably where the most energy is right now. There are the studies coming out suggesting that some people, after they have the acute infection, the virus continues in the body for many, many months to years, causing ongoing tissue damage. And the big clinical trial, the first big clinical trial, will look at Paxlovid in people with long COVID to see if Paxlovid is the drug we use for acute COVID. Chronic inflammation, Dr. Rhoads mentioned this, is probably a major player. Autoantibodies, like lupus. Lupus is an autoantibody where that you turn on the immune system and these autoantibodies attack the body. We're seeing similar types of autoantibodies in people on COVID. And then Dr. Rhoads talked about this quite a bit, the whole issue of the blood vessels being attacked by the virus and being broken down. And broken down blood vessels, she said, is not a happy one. And you have inflammation there and you have clotting and tissue damage, so forth. I tend to think that the virus and the inflammation lead to this blood vessel disease, and the blood vessels are, when they break down, is what's making people sick. And each of these have different ways. So we're about to explode. We're the first big major clinical trial in this arena will be Paxlovid. Let's see if the virus is there and we get rid of it with an antiviral. But there's a whole laundry list of drugs that are about to enter into clinical trials, anti-inflammatory drugs and drugs that go after these autoantibodies and drugs that break down clots. I mean, it's going to be massive. UCSF is well positioned to take part in some of this stuff. The first study will likely be this Paxlovid one, but others are coming. In the meantime, what do we do? And I think, and I'm pushing hard. I'm almost becoming an activist, like I used to be back in the 90s with HIV. But I'm pushing hard now that we really desperately need state and federal funding to build these long COVID clinics. There are long COVID clinics. You have to have insurance, and you have to wait a year to get in there. And often they only want people who have high-end insurance so that they can bill and get all sorts of stuff covered. Obviously not ideal. So we need these clinics to be built in the communities where people have long COVID, make sure they're accessible to all, and make sure they have what everyone needs, which are clinicians and physical therapists. Physical therapists are really critical in this field right now. Social workers, mental health, and so forth. And the clinics that do this right, there are clinics out there that are being built that are actually just profit-making machines, and you've got to be wary. But there are definitely solid long COVID clinics. There's one at Stanford, there's one at UCSF. They take a holistic approach to try to sort of deal with this stuff on many different levels. But the waiting list is a year. So this is not ideal. And then you have to have insurance to get into it, so forth. All right, let me just sort of finish up. We would love to have, we're following Dr. Rhoads' lead and all the community groups that popped up to deal with acute COVID to sort of build the kind of partnerships that work so well with the acute and the vaccine stuff for this long COVID, largely because we want to make sure that what we're doing serves the community, and actually we can understand this disease in a way that's going to be most impactful. So we've been sort of trying to expand beyond in the HIV world. It's primarily we're dealing with gay men, and often it's just white gay men in San Francisco, and we've learned that is leading to problems in terms of interpreting the data and generalizable. So we don't want to, we're trying to fix that problem. And that's why we're here today. So what we have is this link cohort that we started without funding that now is Recover, which is this big federal funding. We have the kind of funding to support community outreach and community and CAB and so forth. And so we're hopefully going to do this differently this time around. Because I think if we do this right, if we manage to engage everybody that's at risk and who needs to be engaged, we can truly find out. It's going to take a while. It's going to take a lot of money, but we can sort of figure out, how common is this in various communities, who's at risk and why, and particularly, what kind of services that we're going to need to build. Because there's a group of people, I'm afraid, maybe 1 or 2% of the American population now who really have just bad, disabling long COVID that's going to be there for years. And so we need to figure out who they are, where they are, and what they need. And that's going to require sustained, well-funded partnerships like the ones we're trying to build here. In conclusion, long COVID is real. I think most people agree. So stigmas should be less of an issue. But it remains quite variable. Everyone experiences it differently. A big challenge in terms of study and drug development, multiple mechanisms. No therapy now beyond what's in the long COVID clinics, but give us time. I think once we have some more mechanistic data, the drug companies will do what they do well, which is develop drugs that I think will work. But it's going to be a while. And with that, let's hopefully have a discussion. Dr. Rhoads, is this back to you?
Dr. Deeks, thank you so much.
Great.
And Dr. Rhoads for an outstanding presentation. Lots of information. We're thrilled that we're going to be recording this because trying to keep up with all the information, I know I found challenging, but insightful and informative. We do have a couple of questions in the Q&A, so I was going to start with those and also just encourage people to go ahead and start putting their additional questions in the Q&A section. So the first one is Charlie, and it says, do you have any data to back up the statement that most people fully recover? All the data they've seen in the patient community shows the contrary. So I don't know which one of you want to address
well,
that.
I said it. That graphic comes from the central, I think it comes from the central Recover. It's been used repeatedly in a lot of these presentations. But I think that what we just discussed is the fact that, like, how do you define it, right? So the idea that most people fully recover, I don't think we actually know that for certain, because we haven't asked every person who's had COVID, are you having residual symptoms? And then we haven't gone back to them 3-4 months later to say, are you still having, residual symptoms? So I think it's an important point that is being made by asking the question. No, we do not know with certainty and cannot say with certainty that most people fully recover. And I think as we learn more about long COVID, I think we're going to figure out that probably most people don't fully recover, but may have mild enough symptoms that they don't feel like they would call it, long COVID, for example.
Great, thank you. Jerry, last Saturday, Dr. Tony Komaroff, MD, MEC, CFS, which I think is chronic fatigue syndrome, but I don't know.
Yeah.
And long COVID emergent similarities suggested that approximately $3.3 trillion cost to US over the next decade that would double the number of individuals on disability. The good news is that long COVID research should enhance our understanding of MECFS, etiology, and therapies. To date, have either of you learned anything that would contribute to that care of those types of patients?
I'll try that one. There's a lot to unpack there. It's a great question. So there are a lot of economists now who are talking about the impact of long COVID on society. And there's a good evidence now that the workforce problem, the inability to find enough people in the workforce, is due in part to people being out because of long COVID. It's strange though. I've actually had I've actually been working a lot with the Social Security Administration, who are actually really prospectively, they feel there's a tsunami of of disability coming. They haven't seen it yet. In terms of, and I think it's because I actually, there's a couple of things going on. When I talk to some of the people that we're following, they're young people, right? If you're in your 20s, you don't know how to get on Social Security disability. You don't have a physician who knows how to do that. That's just not your world. When you're in your 60s, 70s, like me, yes, that's your world. So there are a lot of people out there who actually, I think, are struggling, who could be getting support, but don't, because they don't have access to clinicians who know how to make the diagnosis and fill out the paperwork. And that's a big issue because this is affecting a lot of young people. And so there's lots of issues there to unpack. The issue of chronic fatigue syndrome, this ME, encephalitis issue. So there's some people say we should keep them separate until we know what's going on, but it's increasingly clear that they're actually related. There's so much overlap. And so, yes, I am optimistic that right now all the money is going to long COVID, and these clinics that are going to be built are for long COVID, but it is going to provide lots of indirect benefit to all these other different syndromes that I've mentioned, post-Ebola, post-SARS, and so forth.
Great, thank you, Dr. Deeks. Cassandra has a question. With persistent infection, will the individuals show a positive PCR test?
I think that's a no. Think about your, having had chicken pox, right? You are potentially susceptible to getting shingles, and it is the same virus. But if actually, what I'm not sure of is if you did a PCR test looking for varicella, would it be positive? And my guess is that it wouldn't be. So I defer to Dr. Deeks, but we do carry, that theory, I think, is based on the fact that we do harbor some viruses over the long term that we've been infected with, but we're not actively infected for the rest of our lives.
Yeah, I mean, exactly. The PCR would be, as Dr. Rhoads said, probably negative, because it's not, so we do the PCR test, you're usually looking in the nose, and PCR picks up the nucleic acid. But by the time people have long COVID, it's no longer in the nose, it's systemic. And so the best way to pick it up is by looking for protein in the blood. So if you have long COVID, your standard at home, anything you're sticking up your nose, those tests are all going to be negative. But the virus is elsewhere, wherever those ACE2 receptors are.
Okay, the questions are flooding in, so let me see if I can keep track here. I think there was, Maria had a question about, oh my gosh, I've lost it already. I think what are the steps, let me see,
that are being taken to engage community that have been historically excluded in healthcare to sustain healthcare access? I think I can speak to that in terms of what we're doing in the Bay Area, what we're trying to do, and what Umoja Health is about. We think of ourselves when we provide direct service as bringing the door to healthcare closer to the people. So we're not asking everybody to come into a facility, but we're trying to establish a relationship by doing the work outside the facility and showing up in the community, answering questions about whatever. It doesn't have to be about COVID, but establishing a relationship that I think starts to give people a little bit of comfort and ease, and in seeking the kinds of care that they might otherwise need besides for COVID. And I will also say that we are expanding our services, and I think across all 3 jurisdictions in all 3 counties, we're talking about what other services can we bring out into the community. One of those services, as open enrollment starts, that we're talking about is having people be prepared to sign folks up for health insurance. Because that is going to be, I think, an important element to how you can access care if you are over the long term after having COVID, suffering from these long COVID symptoms. So that's really what we're doing, is trying to shift and turn the healthcare system and the way it engages with traditionally marginalized communities sort of inside out. We need to get out of the building. And that's really what Umoja Health has been about for the last 2.5 years. Thank
you, Dr. Rhoads. And if I could just jump on that one, that conversation is happening in a lot of places. A lot of community folks are really trying to push that healthcare system get out of the system and actually in the community. So thank you for that. Let's see, we have here Lisa. How can we provide better public and healthcare provider education on long COVID in the Bay Area?
Dr. Rhoads, you want to, because
Don't answer it all at once.
We haven't hosted any forum. I don't know if you did with the link study, during HIV time, but we need to have forums like this actually for providers, because when you go into these social media spaces and you hear folks who are suffering talk about their interactions with healthcare, it really does reflect, I think, not just a lack of knowledge, because I mean we don't know a lot, right? But it also sort of reflects on a helplessness that physicians in traditional medical settings are not comfortable with. Like, I don't know what to do about that for you. And so it's easier to say, well, you're just getting old and maybe you're not trying hard enough, which is a lot of what we're hearing, even as we're out doing surveys and coming across people who do have long COVID, but sort of didn't know it because they really didn't have anywhere to report it. So I think forums like this really should be targeted. Actually, I really think it's important to get to the community. That's like where my heart is. And that's where I feel like the information, we always hold it hostage. But the reality is we could train community and have them ready to advocate for themselves, but then they're going to go into systems where providers may or may not know how to receive that advocacy or interpret the problems that they're bringing forward. So I think we need to have some parallel or some companion town halls like this for providers.
But that requires a lot of resources. And this is my issue, right? Because, if you have NIH funding, which I have a lot of, I am constantly being graded now on to what degree the work that we're doing legitimately and sustainably engaged in these various different communities. And I've been saying, you have to give us money to do this, because we need to find space in these communities. We need to hire people from these communities, train them, and have them, because they're not, and that can be done. And it's actually, that's how HIV care is now delivered in Africa. It's quite amazing. All that stuff is now being done in rural communities in Africa with HIV care, and it's been tremendously successful. And we're trying to do that here, but it requires a lot of money. And so this is what I keep saying is that society, NIH, Congress can't just talk the talk. They actually have to invest deeply in building this infrastructure in a sustained way. And the universities can help, but the universities, particularly UCSF, doesn't have the resources to do this. It really has to come from the federal government, state governments, and yeah.
Thank you. Question from Charlie. What can we do to get public health officials to talk about this? A recent study from the University of Minnesota found only 1% of public messaging was dedicated to long COVID, yet it's the most common adverse outcome from the infection. San Francisco Department of Public Health has only mentioned it once since the pandemic.
I'm annoyed and frustrated by that. I'm going to get in trouble. I don't know who's on this in the meeting, but
it's okay. You can be in trouble with the rest of us.
but it's so easy to measure. So acute COVID was a great public health docs, and it was an easy thing to measure, right? You can measure people in hospital they like to measure stuff. So who got sick, who was hospitals, who died, do an intervention, did it go down, right? And they were great successful, and they had a lot of influence, and they basically, they monopolized the society in 2020, 2021, did a lot of great things, but they have not engaged in this long COVID thing at all. And I don't know why. And I think it's a lot of it has to do with the fact that it's unmeasurable. And they get confused by all this stuff. And I'm very frustrated. I can't answer why. A lot of people, so Congress is paying attention because of the advocacy groups. The advocacy groups are very powerful, and they've got the ear of the Congress, and they gave NIH $1 billion. And so now NIH is paying attention, but you got to follow the money. That's not happening at the local level with the DPHs. And I'm frustrated and I wish it would change.
Well, I would offer a more, I think I would take a historical perspective, which is for those of you who know me, I have this bone about the divorce between healthcare and public health, because prior to the 50s, when the first public health schools were opened, physicians and public health practitioners actually were trained together. And then once we had some, we could cure something, then all of the attention went to healthcare, and public health has been left behind. And even at the beginning of the pandemic, public health was not prepared. To me, I was looking at public health having to respond to an emergency, but having not had the training on how do you respond to an emergency. So I think that public health has been ignored because healthcare makes a lot of money. It's sexier. You're curing people. And so public health is sort of not prepared to respond in this way. What was easy about the acute part for public health was giving a shot and getting everybody a shot and trying to get us to community immunity is actually a public health function. It's prevention, right? But the problem with long COVID, and I can speak for a conversation that I had as Recover was coming online and we were trying to get our public health departments, engaged. What came back was, with long COVID, there's no public health intervention. So yes, counting things is their job. So a prevalence study is an important thing to do because you're counting how common is this? How often is it happening? Who is it happening in? The problem is the fix for when you find somebody with problems is healthcare, and they have no jurisdiction, or at least not a direct, oversight for the healthcare part. And so that was literally the conversation that we had, was like, so what are we going to do about it? And the way we actually helped San Francisco move forward with getting on board was, we said, well, if we do this prevalence study in San Francisco and we find that people are having problems, then we're going to create a resource package and refer them to wherever it is that they can get these resources. So that was enough to say we're at least addressing it, because they didn't really feel like doing a prevalence study just for the sake of doing a prevalence study was a public health function. Is really so that there could be an intervention. So what we offered was that we would try to put together resources for people once we knew that they were having issues. But quite frankly, if public health and healthcare could remarry each other, it's like, mommy and daddy, please stop fighting. There's so many things could get solved because healthcare has the money to support public health activities in a way that public health is not generating revenue by seeing patients and billing patients and getting a facility fee and things like that. So there needs to be some synergy there.
Thank you, Dr. Rhoads. And this is Charlie again. In March 2020, he's 32 years old now, and it's just now navigating the long-term disability. So Charlie, sorry to hear about that. And I don't know if there's a question or if you need a resource, but let us know about that. And that's really what's been coming up a lot. I mean, a lot of folks that I've talked to who may have long COVID, or they know somebody with long COVID, this whole financial disability piece keeps coming up. And as was earlier mentioned, the cost of folks who have long COVID going on disability is tremendous. So I don't know if there's thoughts about that, or what your perspective is on that.
I mean, I think I think a lot of people are struggling because they don't have access to, as Dr. Rhoads mentioned, healthcare that can deal with this. It's actually it's a complicated syndrome. You have to have some expertise. And even if you can't provide any cure, you can provide a diagnosis, and you can and you can give people resources. There are a lot of underutilized resources out there in terms of accessing better insurance, but also disability insurance that could be temporary or more sustained. Yeah, so it's a big failure right now, the healthcare system, that is going to require, I don't know, how are we going to fix this? The Brits do it very well, by the way. This is actually in the UK, United Kingdom, and Israel, and a few other countries that have more socialized medicine, where it was very easy to repurpose existing medical systems to do this. And so, yeah, so most of the best data we have in terms of what's happening is coming from those countries, because they're set up quite differently than the American healthcare system, which we all understand, which everyone knows is a disaster.
And the difference is not just about the payment systems. The difference is the emphasis on public health, prevention, right? Keeping people well. We have a system that actually makes money off of people being sick. So there's like very little incentive to invest in people being well. And so we say, use socialized medicine as sort of a coverall, to describe something. I think the chunk that is missing, or the chunk that you're actually describing, is a commitment to public health and prevention, and allowing that to influence healthcare. And we definitely do not have that in this country.
Because it's sounding like a vicious circle, right? Like if healthcare provider is not well educated around long COVID or any condition of that matter, then the patient kind of is in a kind of a perilous kind of situation, because if they need that healthcare provider to help them with the paperwork for the disability, but they're not aware of how to do that, then it just seems like it's perpetuating over and over again. So and Dr. Deeks, your example of the Brits, do we know like what the Brits are doing, like specifically some examples of how they're managing this?
Well, everyone has the same healthcare insurance. Everyone has this, works in the same healthcare system. There's not a lot of money in the healthcare system, but it is a unified healthcare system. So when there was a new syndrome, all they had to do is retrain the social workers and some of the clinicians in each of these centers to sort of begin to deal with this, and it's off to the races. That's very different than a 25-year-old person who's never been sick before, doesn't really have good health insurance, doesn't even know where to go. They have to get the health insurance, and then what, they're going to go knock on the door, and then all these private docs are all over the place, and maybe they see one or two people, but they're not in a community where it's easy to reach out to them and train them, and and again, and physicians in the United States are always trained to take care of the individual. We don't have that public health perspective. It's not part of the American culture. I mean, it's just endless number of issues that really make it much more difficult here than elsewhere.
And again, I mean, think about who's paying. That's why you see things look differently in a Kaiser and a VA, because the Kaiser and the VA are paying for the care. So they don't want the person to be almost dead and having to go to the ICU because it'll make more money for the hospital. What that means is they have to pay more money out of their pocket. So the system that's in a socialized medical system, there's effectively one payer. It's the government. So the government doesn't want to be overpaying, and the government doesn't benefit from people being sick. What we have is fully privatized. So if you're sick, then somebody's going to make a lot of money off of you. And if you're going into a hospital, a system's going to make a lot of money off of you, regardless of what happens, because they get a lot of money for you just having yourself inside their hospital in a bed. And so that's, you just have to follow the money. And when I say follow the money, I don't mean who's making the money. I mean, who's paying the bills for the hospitalization.
Wow. Okay. That sounds like a lot to manage. So we're gonna put that in the parking lot for now, but we need to talk about that some more, but we're gonna try to get to some of these other questions. Marcia, what type of eye problems do people with long COVID have?
Eye problems. Wow. There's a whole program that's been funded to look at this. It's not a major part of what we see. But I've heard that there is a subset of people who are developing visual acuity issues. Not super common, but it does occur. Don't know much more about it.
And by visual acuity, you mean like their ability to see far or close, or need glasses maybe? Yeah.
So, I vaguely recall hearing that cataracts can also be more common in people post-COVID than not. but I'm way beyond my area of expertise.
All right, next question. Kim, is there an opportunity to prioritize interventions for first wave folks who have been waxing and waning? Temporarily improvement are followed by worsening baselines.
The first waivers are, so if you talk to long COVID experts, people who have a lot of experience, they'll say that the worst long COVID are the first waivers. You see bad long COVID, but it was the, and I assume it's because the virus was new to people, but it was also these high exposures that people got back when we didn't know about social isolation and distancing and masking. The problem is that, again, there's a big battle going on right now in terms of this NIH study Recover. I think Recover should just focus mainly on people who have long COVID versus not, but that's not what we're doing. In the Recover study, we're only looking now at people who are becoming infected today with Omicron, and then we're going to follow them over time. And the first waves and the second waves and the deltas are being ignored. And that's a big problem. And because I think that's where most of the unmet need is. And I think that's where therapy should begin. And yeah.
So I have a follow-up question to that, and that is why? Why was there a decision to start ignoring the people that had COVID, and now we're focusing on the folks who are just getting it?
Well, we're not ignoring them. They are part of the study, but they're de-emphasized. It's because scientifically, I mean, it makes sense scientifically. So the great need is the first waivers and so forth. But it's really hard to figure out mechanistically what happens because it's already happened. So scientifically, it makes sense. It's much easier to figure out scientifically what's happening if you measure people when they're healthy and then follow them over time. And so that's justification. But I don't think there's going to be a ton of bad long COVID going forward because everyone's vaccinated and Omicron and this and that. So it's a scientific debate right now is where should the resources go? But right now, I think the first wave, second wave people are sort of being left behind.
Okay. Charlie, the Paxlovid trial is set to start in January 2023, but not finish until 2024. But it's only a 2-week regime. Anything we can do to advocate to speed that up?
I think it's going to take longer than that. So that study is going to enroll almost 2,000 people in 100 centers. So you have to get ethics approval in 100 centers. They're only now picking the centers, and you got to get all the contracts and everything else done. And then you have to go out and find people. And then so the NIH is under a lot of pressure to do this as quickly as possible. That's a very aggressive timeline. We did it with COVID vaccines, but that was a different era, right? That was an all hands on deck thing, right? The whole country had shut down. We don't have that same urgency with long COVID. I think there's going to be we're going to do a smaller study than the big Paxlovid one. So there will be, it's in some centers, we'll be doing more intensive studies with readouts that'll be a bit quicker.
Next question is from Diane. Is it possible for second and third COVID infections does that increase your risk of long COVID?
Not really known. It increases your risk of PASC. PASC being heart disease and diabetes and strokes, that stuff. Your risk of getting that stuff goes up each time you get COVID. It goes up a little bit every time you get the flu. So that the risks aren't great, but they do go up. But the long COVID stuff, all the vague symptoms we're describing, it hasn't been, we don't know yet whether the second and third infections increase the risk. I suspect it does.
Okay, Jen, is there any data that shows if there's a cause and effect of having long COVID and previously having Lyme disease?
That's a good question.
Good question. So prior autoimmune diseases like lupus and so forth increases your risk of developing long COVID. But people who had got Lyme and then chronic Lyme, one would expect that they're predisposed. So I don't know of any data on this, but it would make sense that that would be true.
Charlie, again, prevention is the best way to prevent long COVID. That seems to be the elephant in the room. Yes,
Good
and
point.
elephants are my favorite animal.
Yeah. Best way to avoid long COVID is don't get COVID.
Right. So
And
that
we-
means, go ahead, Dr. Rhoads.
Well, I was going to say, and we do talk about that in all of the Umoja spaces, as you know, President Biden declares that the pandemic is over and people throw their masks away now because they're not strongly recommended. We're still pushing on masking, and we're still out here trying to get people vaccinated, because that is the elephant in the room, and that is the reason to not get long COVID. And it is also the reason that we have taken it upon ourselves as a 3-county coalition to start to develop the messaging that hopefully you will see if you are on public transportation, or if you're anywhere near any of our sites. We're still trying to encourage people to avoid getting COVID. But I do also want to be clear that we also have people who are embarrassed, right? They've gotten COVID and now they feel ashamed because we've sort of said, you should be able to prevent COVID. And I just want to make sure that we continue to embrace the folks who have gotten infected so that they don't feel ostracized. Otherwise, they're not going to share that they have COVID, and we're really not going to understand the distribution of the long-term effects.
Thank you, Dr. Rhoads. Jen, I'm fortunate that I have good insurance, and I'm in the Stanford Long COVID clinic. But even so, I've had to spend over $10,000 out of my pocket to do so many tests that seem to be just trying anything and everything. In the community forums, there are many things that I've done that most, if not all said, didn't show anything for others. How much should I actually keep putting myself through? Great question.
Yeah, I don't blame, if you have the resources. So I took a slide, I had a slide that of all the stuff that people are doing right now. It reminds me of Dallas Buyers Club. I don't know if people remember that movie about the desperation of people who had AIDS, stuff that we would do when there are no, and people are sick and they're previously healthy, they're desperate. And so I don't encourage, but I certainly try to guide people into doing things that make the most sense. But yeah, it's often very expensive, and it typically doesn't work. I think we're in the last year, 2 years, it's been the wild, wild west, right? Society got blown up. We're still trying to figure out what the heck long COVID is. People are now accepting it. We're getting more rigorous now and prospective, and legitimate studies of drugs that could work are about to start. So I would shift my focus from measuring everything that you can measure in the body with all these MRIs and everything toward participating in the best clinical trials available, because they are coming finally.
Thank you. Someone from New Voices Are Rising. How are youth age 25 and under disproportionately impacted by the long COVID and its impact? Do we know at this point how it's affecting young people?
So young adults, it's not as common, but severe. But a young adult who gets disabled is a profound thing, right? It's because you're taking out years of the best luck. So it's less common, but it certainly occurs. Children, we haven't talked about children, but MIS, there's a pediatric version of long COVID that can be quite disabling, and was not uncommon back in the first several waves. It's much less common now. It's much more inflammatory in nature, and there are some treatments for it, but it's a whole different disease, pediatric long COVID.
And I see 2 questions from Jen here. The long-term disability is horrible. It took her months to get approved while she was off with no money coming in. they seem to lead with not wanting to rely on the diagnosis. And she's lost a lot of her vision. And it gets worse when I feel worse. I often have to close one eye to see. So Jen, sorry to hear about that.
I want to comment on the long-term disability piece. And I just want to take this moment to encourage people that if you do test positive for COVID, please make sure that that gets documented in the state system, because, for all of this testing that we're doing at home now, and people are not reporting it into any, permanent record, who's to say you had COVID, right? You have no proof of that test. So in terms of getting disability insurance, in order for someone to make the diagnosis, the first thing they have to establish is that you had COVID at some point. So just please want to take that opportunity to let people know, please continue to report your positive tests. So you have that documentation for disability.
And then Lisa has provided a link with the list of symptoms around vision.
Oh, good. All right, let me see if I can find that.
So it's blurred vision and cataracts and some other things. So thank you, Lisa, for providing that resource.
Oh, Lisa McCorkle, yes. No, okay, good. She's definitely an expert. Got that, Lisa.
Okay. And then she also mentions that part of the reason people in the first wave may be worse off is because the lack of information available and the immense medical gaslighting experienced. So people pushed themselves and received less quality care at the beginning of their long COVID. That makes sense.
Yeah, that gets to an issue of how to manage some of the symptoms, including post-exertional malaise and the issue of pacing, right? So a lot of clinicians will say, okay, you're feeling down, you're feeling fatigued, just push yourself, go out and exercise more. And that actually can make things far worse. And that's something we're learning from the chronic fatigue world, that and this is where you really this is where you need access to legitimate expertise in some of these very complicated issues of how you pace yourself, what kind of exercise you can do, when you should do it, what kind of physical therapy you should do, and so forth. And there's probably only a handful of people in the country that know how to do this, right? And they're helping people now through telehealth and so forth. But we just need a massive increase in the workforce, people who know how to manage some of this stuff.
So that brings up another question that I have, since we're on that topic, is where are the best places for people to get accurate information? Because it really seems to be, kind of this hodgepodge. We now have the, social media and Facebook and all this stuff, and people are getting very confused. They're not sure, what to believe, not to believe. So can you give some suggestions about what are there tried and true places that people can go to get accurate information about long COVID?
So Lisa is providing. So I wish Lisa was able to speak to the group, because she's one of the leading advocates in this and involved in multiple groups, including Bali Politic, that have tremendous resources. So there's a link, wearebodypolitic.com, COVID-19, that she put in the question and answer. That'd be a good place to start.
Great, thank you.
I'm going to put that in the general chat for everybody.
Oh, okay. So that's just for us. All right.
Yeah. So all attendees, look at your chat button. That link is in there.
Great, thank you, Dr. Rhoads. Let's see, Kim, this is a question from Kim. Can we mobilize the healthcare workforce who can't work clinically to provide clinical education, case management, navigation? I have excellent insurance, but despite the $50,000 spent on providers, have yet to have one encounter one who knows about long COVID, despite the labs, the MRA, the nerve conduction studies, nobody knows. And maybe even saying maybe you're developing, Alzheimer's, or a peripheral neuropathy and cramping, et cetera, or you have an anxiety. So it's almost sounding like the other person, Jen, like, it's just like this crap. It's like, what sticks? We're just gonna throw everything up and see what sticks. Can you guys address that at all? Or not?
She mentioned Dr. Rhoads, so.
Well, no, I didn't see my name in there. It's from Kim D, but I don't see a downside to this, to the suggestion of mobilizing the healthcare workforce who can't work clinically. So what you're saying is like people who have the expertise to help with navigation, et cetera. I think that's a brilliant idea. I don't know where you find a group of people who just declare they can't work clinically. Part of what we do when we're doing direct service out in the community, we do need providers who are willing to spend additional time, out in the community, answering questions, giving shots, doing whatever. So I do think that it's a good resource to be able to go to. I just don't know of like where you would find a whole group of people who are unable to work clinically so that they can, have time to do this other kind of work. But I agree with you. I mean, that is something that we definitely need, because being on the outside of the institution, I think, is what is going to, help people feel more engaged and be more engaged on the inside. And we do have secret tricks, like we know what the back line is, and we know to ask for the new patient coordinator, and but most people who are clinical are working clinically. It's kind of a rare kind of person who is sort of like me. I clinically retired at this point, and so provide my expertise out in the community.
Yeah, but I think long COVID is going to force us to think differently and come up with new systems. And I think telehealth is going to be really important, because long COVID is everywhere, right? So again, I keep coming back to the HIV story. HIV was largely in urban settings, and so it was easy to build centers of excellence in San Francisco, LA, and so forth. But long COVID is everywhere, and the rural communities in particular seem to have been hit hard by this. And there are many reasons for why that might be. And you're not going to have a long COVID clinic in every rural community in the United States. And so telehealth is going to be a major player in terms of delivering care. And of course, that can be done by anyone, anywhere.
Another question from Charlie. Do you think public health officials would be receptive to changing their policies and messaging, or are they getting all their cues from the federal level?
Well, I think we can speak directly to this. I mean, we meet with San Mateo County Public Health, San Francisco, and Alameda County, on at least twice a month as a coalition. And the answer to that, I think, is no. The answer to it is, you're right. They're getting their messaging from CDC, and then comes to California DPH, and then the public health departments locally are following Cal DPH. So, and then the other thing to remember is that without the emergency declaration, they really have no enforcement power, right? So they can say a lot, but they can't do a lot about it once a declaration has closed out. We have tried to encourage them that we're not asking you to make a mandate. We're asking you to model what you think COVID safety is. For example, go ahead and say it's airborne, because guess what, y'all? It's airborne, right? So we've been pushing on that. That helps people understand why you might want to wear a mask, because it's airborne, right? Instead, they got you washing your hands, and washing hands is good, but it's airborne. So you need to cover the portal of entry, which is your face. So we've been pushing them, but they are restricted in some ways. And I'll just, go one level beyond that. When the First Lady was in town just recently to visit the cancer center, she was like, it was a little touchy about whether or not you're going to be wearing a mask with her in a picture. So there is kind of a federal, party line and talking points that are being, pushed. And I think public health departments, because they have no enforcement jurisdiction, really just kind of have to follow within the limits of what they're able to do, which is recommendations. So yeah, they are beholden to the federal government. But again, that's also why Umoja is now shifting to creating our own messaging and, saying what is true to try to help keep the communities that we're trying to serve and the frontline workers and all the people who couldn't hide inside and work from home, trying to keep them safe by really putting the word out about like the truth about what this disease is about. Another reason why we're even doing this forum.
Thank you. And then another question has come up from Maria. What are some of the steps that community members can use to advocate for themselves when they're seeking care for long COVID?
I think, again, some of the body politic link will provide people with the kind of information that will empower them in their interactions with healthcare. And I think the vast majority of people, because they don't have access to especially care, are going to run into well-meaning clinicians who are just overwhelmed, only have 10 minutes to hear a story that will take an hour. And, clinicians are trained to fix things. And if you can't fix things, they moved on very quickly. And so you're going to have to come in with information and educate the clinician and insist on largely on hopefully getting referrals to kind of therapy that's necessary out there. But I think you're going to have to be your own advocate, and to be your own advocate, you're going to have to enter the healthcare system with knowledge. And there are these links I think that we can put in the chat here that for where people can start. I don't know.
So Dr. Deeks, I just want to push on that a little bit with you.
Yeah. Uh-huh.
And that is, we've got folks here that are really struggling. I mean, they're trying to keep food on the table and a roof over their head and, kids in school.
Right.
So what is, not that you shouldn't be an advocate for yourself, and how do we lessen that burden though on folks who are struggling?
Yeah, no, that's it. That's it. I mean, I'm involved. So I think there's only one solution. We need to build these big centers and welcome people and fix this stuff like they're doing in the United Kingdom, right? There's these big long COVID clinics. Everything that's been written about clinical management comes from the United Kingdom, where they have these long algorithms. You show up, if you're disabled, you get help with the disability insurance, you get access to clinical trials. Short of that, I don't have an answer.
And I think also that's what we're trying to do with Umoja, and Dr. Rhoads alluded to that, is that people can go one place and get all the resources and services that they need. Because when we have folks that are struggling to pay their rent, trying to, go to different doctors and people and go here and there to get resources, it's just additional pressure and strain, and they're already struggling. So I think where we can push and advocate that we need to be supportive of the whole being, right? Not only handling their medical, but also all the other things that are impacting their health. Because, I feel like, well, I'll speak for myself. Yeah, I can be an advocate because I'm living and breathing it, right? And I can be an advocate for folks that I know, but not everybody is in that position. And so we need to figure out how we can help those individuals that are not in the position to advocate for themselves. So I just wanted to push you a little.
Well, it's kind of,
I'm sorry. I'm going to push back and say that I know firsthand that the people with the ability to change the world, the politicians, the Department of Public Health and so forth, they don't listen to me. They listen to community groups. And so you need to fix this, not me.
well, that's funny. But I was, well, what I was
Yes, raise
what
the
I was gonna
yeah.
What I was gonna say is Miss Lisa, what you always say, which is it takes a village to save the village. And we say it takes community to save the community. And it does work. And we have seen it on some things that we needed to get done in San Francisco, bringing the voice of Umoja to public health, to UCSF, actually changed something. So I think that we need to start to exercise that muscle of organization, right? And then you look for your champions inside the institution who, Dr. Deeks is saying they don't listen to him. But Dr. Deeks, you have access to the information that the community will need to bring forward, right? So it's a partnership. You give community the data, community goes to these politicians as voters. So this is how we're going to vote based on what you are or are not doing in response to this, in response to this problem. Or we could go one step further, like they did, around HIV, and we're going to sit in your front yard until we get what we want. I mean, it was a lot more active. Remember, ACT UP? I mean, there was a reason to ACT UP. And we might come to that point where you've got people camped out in your front yard, trying to force the people who are holding formal authority to make change. But I do think it's going to have to be an inside-outside partnership where we provide the data and the stakeholders who are voting are the ones who carry the message. And we support them to carry that message to get the things that we all need, like these big centers that you're talking about.
Right. Right. So yeah, Dr. Deeks, I'm ready to work with you.
I have information, but I have no power. So I'm happy to share my information.
Thank you. Thank you so much. All right. I think we're all, let's see. Oh, where do you think long COVID advocates can get the biggest bang for their buck with advocacy efforts? So that's what we were just talking about.
People who are afraid of the voters. It's just how it works. So to the degree that you represent communities with all these voting blocks, it's just incredibly powerful, and that'll get done. So the most of the success so far has been the federal level. The federal level is hard to get Congress to pay for health care. I'm only learning this myself. They can shift resources for research, and they've done that. But we're talking about care, and that actually that's more of a state thing and a city thing and a DPH thing. And so I think that's where the focus needs to go. That's my understanding for clinics that are focused on many of the chronic pain and everything else that we're seeing with long COVID.
And there could also be some letter writing campaigns. I mean, I just marvel at the fact that Recover is a $1 billion operation. And I don't know if people caught that. It's billion with a B. I'm not familiar with any NIH, federally funded study that is over $1 billion. And I'm sure there are some, but it's not common. And so that, and it was a direct appropriation from Congress, as I understand it.
Yes.
So there's an opportunity to do letter writing campaigns to your local representatives and say, like, hey, you guys just spent $1 billion of my tax dollar on whatever, and I'm not seeing the impact. But it can't just be you, right? You need to gather all the people who are under that same representative, again, looking at voting blocks and actually join together, organize yourselves, figure out what your talking points are, and write those same talking points and flood the zone. So send the letters, make the phone calls, make demands about what you would like to see happening differently. We've never tried it, right? In our communities, right? Because the activism around HIV really was kind of white and male, largely. We haven't tried that, but I think of Baba Arnold Perkins, the former director of the Alameda County Health System and Public Health Department, who says we are not outsmarted, we are out organized.
Mm-hmm. True. Okay, we've got a couple of more here. How do first waivers get proof of infection if they were not able to get tested? I asked 9 months post her infection and was denied by her primary care physician, and was told there's no reason to get no reason to test now.
Well, there are research tests that can be done that can prove prior infection, and they're not easy to get. But I think that's, you know, like in Recover, we definitely don't require first waivers in particular to have the proof, because it's impossible. So if there's a clinical story consistent with acute infection, that's sufficient. And that really has to be true elsewhere, you know, people getting access to disability and so forth. A good clinician can help people get around this in terms of accessing care and insurance and research, but it does require some nuancing. It's a problem.
Great, thank you. Lisa has come back with, can we put this in the chat? This is a guide for pacing, which Dr. Deeks mentioned, which is critical for people who experience post-exertional malaise. So they did.
Yeah, can you put, I couldn't quite figure out how to do that. I've been on Zoom for the last 2.5 years, and I should be able to do that, but I did not. There you go.
Great, thank you. I think Dr. Rhoads just put it in there. Great, thank you. All right, well, we've got about 12 minutes. I think we have a couple of more questions here. Wow, we've got a lot more.
What can I think let's take this. I've tried to sign up for the Recover multiple times on the website since October 2021, never received a response. Now when I look, it says nothing is available in California. What is the best way to get in the study or find a clinical trial site?
Can you email me directly? Stephen.deeks@ucsf.edu, and I'll try to figure out what happened.
And I just put that in their response.
Put my email, yeah, just put my.
Thank you. Lucy, how can community be part of getting the truth out about long COVID?
Well, we are, you know, I know I keep going back to Umoja, but that's where we're doing the work. We're creating materials like little push cards that have information about long COVID. We're using the Recover team as a source of that information, and then trying to put that together either in the Umoja meetings. I don't know what the long COVID cab is going to decide to do, but that's another space where we can produce those materials. And then if you want to get access to those materials, please reach us at info@umojahealth.org, and I will put that in your response. Did somebody click that one away already? Somebody took it away. So I'll put it in the chat. Email us at info@umojahealth.org to request our materials. And if you look at our website, we're actually posting some of the materials that we create. There's a button on the, thank you, Eva, where it says spread the word, not the virus. And you can click on those buttons and they'll take you into a folder where you can download some of the materials that we have created to get the word out about different topics.
Okay, we've got a couple more here. Sarah, this question keeps coming up about educating physicians and healthcare providers. According to the UCSF webinar a few weeks ago, there are possible mechanisms and various trials starting. She says that every doctor she's seen, including a UCLA neurologist, don't know anything about long COVID. So where should we be directing? So if we come across that as a patient, is there a website for physicians around long COVID that we should be directing our healthcare providers towards if they're not educated on long COVID?
I think the Bali Politic link that Lisa shared would be a good place to start. Yeah, I mean, I think a lot of what's happening with long COVID is a neurologic issue, and I cannot find. There's only one neurologist at UCSF that will even talk to me about long COVID. The rest can't be bothered, and I think it's because there's no treatment. And everyone's so damn busy. So it's definitely a problem. There are only a few legitimate experts, and they're all so overwhelmed right now. And yeah, we need to get healthcare providers, you know, more training and more expertise. And anyone ever asked me to give a talk on this, I'm happy to do it. But, you know, healthcare in general, particularly in the Bay Area, is a bit of a mess. I don't know if people, even if you have insurance, you can't get primary care docs anymore because primary care docs are leaving the city because they can't afford it. And they're being overwhelmed by all this regulatory stuff and medical record stuff. Primary care is a big issue in healthcare now. And this is a primary care problem largely right now. It's a lot of issues that are going to be difficult to fix.
So I guess I have a question to follow up that. Is there like the AMA or some kind of governing body that can help with that, with educating folks, with, you know, is there some holy grail of, you know, is there some organization that can help with this, or is there still a lot of confusion? And
I want to go right back to that $1 billion because
that's a lot of money.
Right, it's a lot of money. Recover does have, and if you go to, I'll have to find I think it's recovernih.org. I'll have to look, but they actually have webinars on a regular basis of like, what is new? What have we learned? And they'll be in different topic areas. So it might be, you know, pediatric this week. It might be neurologic issues in long COVID. It might be, you know, thrombotic or clotting issues in long COVID. So the talks themselves, I mean, I logged into one, they're very dry. So if you're not, you know, at that level of dialogue, then they're not as helpful, but that is a resource for providers. I just don't think that they're aware. I personally would not have known about this study had I not, you know, been invited to participate with the team at UCSF. So I just don't think they have not done a good job of marketing, because they really do have a website where you can kind of access some of this information.
Or maybe there's sort of like a celebrity physician. I mean, I'm just throwing stuff out. Like, is there something that will grab people's attention so that they, you know, might pay attention?
Well, I don't know. I mean, Justin Bieber's got something. I don't know what it is, but he's got something. And his wife is like having strokes left and right, and she's like 25. So that doesn't seem to capture people's imagination. I think people are so wanting this to be over.
Yeah.
And I think they're going to be so disappointed to find out that it's not over.
And then a comment here says, just because something is called long COVID, it's called a long COVID clinic, doesn't mean the physicians are up on the latest research and are supportive of patients. Some are focused on getting people into narrow research studies. If we push long COVID clinics as a solution, there needs to be some baseline of care. Couldn't agree more.
Totally true. So buyer beware. There are some legitimate clinics out there, but there are some that are all about making money.
Also, there's this question about continuing education credit. Is that another option?
Oh yeah, that typically, so, and I don't see a lot of CME options. UCSF is having a course on COVID in a couple of weeks. It's providing CME. It's not all, it's long COVID's only a small part of that course, but it'll likely grow over the next few years.
And then Lisa's also put some additional links around CDC guidance and AAP, MNR have developed some guidance. I think that's the American Association of Physicians, blah, 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 blah. And I see the recovery websites also in here. Let's see, we've got 6 minutes, so we'll take a couple more and then we'll wrap it up for this evening. It says, have y'all presented, this is Lucy, presented in ground rounds or to providers at San Mateo Medical Center or the health systems in San Mateo, Alameda, Santa Clara, and San Francisco counties?
I have. My colleague, Michael Peluso, who's really the UCSF expert, at least at our hospital, has done many of these types of presentations. Lakshmi also is a physician at UCSF that has done a lot of community education, very committed to this. But it's just a handful of us, and we need more help.
Got it. But I think that's still a good question, though. I mean, we might be able to help with in the San Mateo area. We might be able to influence that a little.
Stanford is a powerhouse. Stanford's in San Mateo County, right? I think
It's half their catchment area is San Mateo, the other half is Santa Clara.
Mhm.
I'm a recovered Stanford faculty member.
Yeah, no, UCSF and Stanford have a long friendly competition. It's hard for me to say nice things, but Stanford has deep expertise in some of the biologic stuff and this great clinic. So if you're in San Mateo area, try to gravitate to, and they have a recover cohort that's well run as well.
We've actually, I belong to several cabs. So one of the cabs, we talked about Stanford and just as they expand their catchment area, that they need to not only build nice fancy buildings, but also get out into the community.
They have to get, yes, good advice.
And, take their expertise and resources and really, go out and meet some folks. Those conversations are happening. Folks are receptive. Receptive. We'll see, how down the road, but I want to say that those are some critical conversations that I know have been going on, but they're continuing as well. So.
And also, I just want to go back to the organizing piece. Jackie Spear, Congresswoman Spear, although she's terming out or not running again, she is an advocate on these issues. I think to push, writing letters saying, you just appropriated $1 billion of my tax dollars. I mean, I just want to say it again and again. Where is it going? How are we not educating our people, right? Get the talking points together and have lots of people write the letter and lots of people sign on.
Advocacy. So it's now 3 minutes to 7. I want to be respectful of everyone's time. I want to thank our outstanding speakers today, Dr. Rhoads and Dr. Deeks. I also want to thank our interpreters who were translating into Spanish. Thank you so much for that. I also want to thank the co-hosts and sponsors, Peninsula Healthcare District, Rafiki Coalition, UCSF, and Umoja Health Bay Area. And we look forward to gathering again as this will be recorded as we discussed, and we'll make sure that the link is provided so that you can hear about it, go over the slides, the data, get all the various links, get emails if you want to get more information. This was I think a very informative and insightful conversation, and the conversation doesn't stop here. I mean, this is going to be an ongoing conversation and an ongoing, not only conversation, but action steps. So I think there's a theme that we heard was advocacy, and then it's going to take all of us. As Dr. Rhoads quoted me, it's going to take a village to save a village. And so that means everybody has something to contribute to the table and can work together to make a difference, because long COVID is unfortunately going to be with us for a while. And we need to really figure this out because it's going to have devastating consequences, and not just from a health perspective. We're going to see our economy be impacted by this because people can't work or they can't do other things. And as we also have mentioned, sick people can't work, sick people can't shop. So it's not just about health. I mean, health is very important and that's at the top of the list, but it's going to impact us another way. So I want to thank also everyone who joined us on this call. Thank you. When you get the link, share it, discuss it with your friends and family, colleagues, your neighbor, because we need to really educate the community. And I holistically mean the community and your physician and primary care physicians. Share it with them as well. And because it's going to take all of us to really address this issue. So I don't know if Dr. Deeks or Dr. Rhoads have any parting words before we sign off. So I'll give you that opportunity to do that if you have anything else you'd like to say.
I would just like to say what I think you're describing is the health of the body politic. So I am I love that metaphor so much. So I'm going to be looking into the wearebodypolitic.com. And I want to thank the Lisa for putting those links in the chat. It is going to take all of us to get out of this. Long COVID is here for the long term.
Dr. Deeks, any parting words?
No, I mean, it's been very informative for me. These questions and discussion have been great, and it's actually been very enlightening, and I've enjoyed the meeting. I'm inspired. I'll do my part.
Thank you. I'll buy you a cup of coffee.
It's time for a glass of wine, though.
Okay, everyone, have a nice evening. Be safe. Make sure you're vaccinated, boosted.
Yes.
Wear a mask.
Mask.
Wear a
Yes.
Wear a mask. Wear a mask.
Please wear a mask.
And so have a nice evening. Happy Halloween's coming up and other holidays. So thanks again for joining us this evening. Take care now. Bye-bye.
Bye-bye.